fracture of the femur. Let's first give the classification. Okay, so this is the classification which you see on your screen is a all lower limb classification, which means that we are we're starting from the pelvis. Okay, injuries around the hip joints, which include the pelvic fractures, femoral neck fractures, which I believe you already finished, proximal femur, hip dislocation. Then next we're going to cover the shaft, the femur fracture, which is one of the easiest topic to discuss, but not to treat. Okay, treatment of the femur is disaster, but discussing it easy, just like the humerus shaft, fibula tibia shaft fractures. Okay, injuries around the knee joint, which is one of the complex, difficult topic, because knee is a difficult joint. Okay, we don't just cover the fracture of the bones, but also we don't talk about the ligament injuries, the meniscus injuries. Then it's going to be tibia fibula. That's it. Okay, we go forward. The ankle sprain, ankle strain, ACL injury, intra-articular talus fracture, which are not discussed usually in the practice classes, but superficially covered in the lectures. Okay, injuries to the foot, forefoot injury, midfoot, and hindfoot injuries. Okay, let's get started. This is the injuries around the hip joint, and briefly talk about the anatomy of the hip joint. So why it is important? Because the hip joint is not the regular joint. Okay, it doesn't straight bone. It's not straight like this. The upper third part of the hip is flexed like this, and it forms 135 degree. It's called neck femur angle. Okay, neck shaft angle. And this angle is important because when you start the treatment of the neck of femur fracture, you have to lean to this angle. You have to be close to this angle. Otherwise, the patient might have some instabilities or incongruency and so on. So also, one of the important thing is the vascularization of the neck of the femur or head of the femur, because especially to the patients more than 60 years old, it may cause some problems. Okay, it's called avascular necrosis, and this is happening because of less blood supply to the head of the femur. Even if the fracture happens not to the head, but the neck or intertrochanteric fractures, in this case, the patient has more chance to have the complications, which is called avascular necrosis. Okay, so there are 3 blood supply vessels, and these are intracervical vessel, artery of the ligament teres, and retinacular vessels. Then in case of the dislocation of the head of the femur, then we have the injury to the ligament teres artery. So no more ligament teres here. Then the retinacular arteries will be working not properly because of the dislocation. The retinacular vessels get stretched out. Only the one vessel can support them head of the femur, which is intracervical vessel. But if the patient has a neck of the femur fracture, the intracervical vessels get interrupted. And this is the most important vessel in this area, intracervical vessel. Okay, most of the blood supply comes exactly from this vessel. So let's talk about the neck of the femur fractures, the etiology. So more clear, because this is happening because of the osteoporosis. I hope you still remember the neck shaft angle, which is 135, which is not anatomically good. If you press the bone from up to down, if it's vertical, then it's not happening anyway, right? But if it is flexed like this, and then you press from up down, of course, you have the chance of the fracture on this area. But the nature is smart, and it is making the bone harder because of trabecular structure. And this trabecular structure is giving the power and the, what is it called? Solidness to the bone. And that's why we don't have the fracture in the age of 40 and minus, okay? Or, unless you have some extra diseases. Everybody jump, run and fall, but no one has the fracture. But later, when the osteoporosis gets severe, especially in the women, it may turn to the big problem. Okay, the mechanism can be different. So starting from the simple squat to the severe RTA, road traffic accident. So their classifications are actually very broad classification, but there are three main classification in this neck of femur fracture, which is called anatomical classification, which depending upon the place of the fracture. It's subcapital, transcervical, and basal. Then next classification is called Powell's classification. It has three types, and 30, 50, 70 degree, depending upon the stability. And then last classification is Gardner's classification. In this chart, it's given 4, maybe 5 types of classification, but anatomical, Powell's, and Gardner's, that's enough. Okay, let's take a look what is next. So classifications are finished. Actually, the neck of femur finished. But for the neck of femur, it is not given any diagnostic techniques, any treatment techniques yet, because neck of the femur as well as the proximal femur fractures can be treated by same techniques. Okay, principles are the same. So the proximal femur, what includes the proximal femur? It is trochanteric fractures, subtrochanteric fractures, intertrochanteric fractures. So let's talk about the subtrochanteric fractures. Subtrochanteric fractures are the fractures which goes below the lower trochanter, and 5 centimeters below the lower trochanter is called subtrochanteric fractures. The fractures which occur between the trochanters, greater and lesser, is called intertrochanteric fractures. So the type of the injuries can be also different. Road traffic accident, falling, dancing, sleeping, and anything. Okay. The classification can be Fielding's classification is not very popular, but the tubular bone fracture classification can be applied in this subtrochanteric fractures. And this is also not popular classification. You don't have to remember everything from here. Okay. So, okay, and let's get to the treatment. But before, before the treatment, let's do the diagnosis, okay? What is the diagnosis? Diagnosis means that you are trying to make the diagnosis, correct diagnosis, according to what principles you have to diagnose, as well as the upper limb injuries. You have to, of course, talk to the patient. What happened to you? What exactly happened? Where do you have the pain? What was the mechanism of the injury? And maybe where the pain irradiates, and so on. The next is instrumental diagnosis. The instrumental diagnosis include the X-ray and the MRI, maybe CT scan, if it's necessary. Then, after the diagnosis, after the final diagnosis, you have to make the treatment, okay? And the treatment includes two types, always two types of treatment, which is the non-surgical treatment, and the second is the surgical treatment. Non-surgical treatment includes every type of the fixation from the outside, the proximal femur. Unfortunately, the proximal femur is not easy to fix because stabilize, because it is very deep inside the muscles, and you may not place the plaster of Paris right around the hip joint, but you can control the movements of the lower limb. Okay, that's why we apply some special shoes for the patient, and it doesn't allow the patient's foot to rotate here and here. It's called the rotational shoes. The next is the surgical treatment, which includes, of course, the intervention, surgical intervention into the joint. And we can apply any different type of the fixators, like dynamic hip screw, proximal femoral nail, and so on. So here we have a fixation technique. On the right left-hand side, you can see the intramedullary nail with the locking screws. And the right-hand side, you can see the blade plate with a stabilizing screw. Here you see the X-ray picture with the gamma nail fixation. The gamma nail is exactly the same as the intramedullary nail, but it's shorter, okay? Let's talk about the trochanteric fracture. Let's not to cover because it has the same as trochanteric fracture, and it's actually short, okay? Treatment, non-surgical and surgical treatment. So see here on the X-ray picture, you can easily see the edges of the bone here going and staying on this side and goes up. But the other side of the bone, distal part of the bone, see the neck shaft angle here, it's not 135 anymore. It is less than 135. And also the distal femur made the external rotation. Here we have the non-surgical treatment of proximal femur fractures, which include the Burler brow traction. On the Burler brow splint, the traction. And surgical treatment includes also the same, like close technique, and then intramedullary nail fixation. DHS stands for dynamic hip screw. PFN stands for proximal femoral nail, Anders nail, gamma nail, and so on and so forth. So here is the dynamic hip screw we can see, and the intramedullary nail or maybe gamma nail can be here. The hip joint dislocation is not very difficult topic. It's just like the shoulder joint dislocation. just like the shoulder joint dislocation. So yeah, ده هو لسه مطلوب ايه كده مش كاتشين. Sorry. Okay, anterior, posterior, and central dislocation. Okay, anterior, posterior, and central. I hope you remember the classification of the shoulder joint dislocation can be anterior, posterior, and superior, right? Not superior, but lateral. So here it's demonstrating the different type of the dislocations. And what is the appearance of hip joint dislocation? If it's anterior dislocation, the knee joint is flexed and externally rotated the limb. But if it's posterior dislocation, internally rotated limb. So let's talk. No, not important. So one of the mechanism of injury or posterior mechanism of injury is dashboard injury. The patient in the road traffic accident hits the dashboard with the knee. You can see the arrow, and it will just kick out the femur head from acetabulum. So clinical feature is complaining the patient to the unable pain, of course, unable to move, restriction of the movement. Then treatment includes the reduction. Different type of the reduction. Здрасте, доброе утро. Да, да, я понял, да, я сейчас хорошо, понял. Сейчас, ага. Okay. Treatment of the hip joint dislocation include, of course, close reduction and open reduction. But the technique of the close reduction can be always cannot be always successful. That's why we have to do the open reduction sometimes. And there are some indications for the open reduction. Okay, open reduction is always surgery. When you do the surgery, you have to open the wound, open the dislocated part.